Hello, my name is H Fretwell and I am a trainee advanced clinical practitioner. My aim today is to discuss the professional identity of my role and the acceptance of myself and my colleagues into the orthopaedic working environment I am employed. This will include the macro level, through the political, social and legal aspects of a trainee advanced clinical practitioner role, the cultural everyday practices of my role within healthcare, the meso level, and finally, the micro level of my own risks and governance within my own professionalism and competence. First, let's get some context on the role of an advanced clinical practitioner and the macro level. Until November 2017, there was no clear definition of advanced clinical practice. This lack of clear context for the role allowed multiple variations to appear throughout the National Health Service and in the UK as a whole, and further afield across the whole world. As identified by Triggle for BBC News in 2015, there are 64,000 nurses working in senior roles across the National Health Service. These senior nurses undertake the traditional medical tasks, such as prescribing, ordering x-rays, referring, and diagnosing patients, and work under multiple job roles, adding to the confusion. These job roles include nurse consultants, clinical nurse specialists, and nurse practitioners. Through the development of a definition, these roles may no longer seek to exist. They will probably exist, but may evolve to incorporate the specification made by Health Education England for advanced clinical practice in 2017. The biggest focus and contrast between these roles, and a very simple identification from the definition, is the lack of a single set profession, such as a nurse specialist or a clinical nurse specialist. Advanced clinical practitioners will come from a range of professions. These will include physiotherapy, paramedic practice, occupational therapy, and of course nursing. These individuals will work autonomously with qualifications at master's level, as well as the skills and knowledge at a competent level for expanded roles of patient care. The role of a trainee advanced clinical practitioner, and the role I am currently employed in, was developed within my trust 2 years ago, and I am part of the first rotation of trainees due to be fully competent and autonomous in our practice in February 2018. The introduction of a new role into an established team of clinical nurse practitioners was quite contentious at the time of my employment. I joined a permanently employed members of staff, a very competent team of 5, which could be argued advanced clinical practitioners who had had to reapply for their own jobs within a trainee capacity. So having come from a very different environment, this was quite hard. However, as CARE identified in 2016, the numerous complexities, such as those I just identified, on all reliance on the ultimate success of advanced practice roles, all depend on the nature of the organisation they are utilised and medics and nurses working together. Consequently, as I find myself, and as Marsh identified in 2011, being a nurse leader and influencing this change is a fine balancing act. And boy, did I find it a fine balancing act. However, it's vital for the successful implementation of a trainee ACP role. Even more so, as in my own trust I am employed, a financial change was needed. A high turnover in locum staff for the medical department ensured that our role would be utilised appropriately come 2018 and needed the role to be successful. This collaboration of the nursing and medical model for a change was essential for the trust. Subsequently, as March 2009 identified and previously commented earlier, the medics and nursing team and the model in which they work needed to work together to collaborate to ensure the change was effective. Having ascertained what an ACP role is, and my own role as a trainee ACP, let's progress to discuss the complexities of my professional identity and acceptance into the orthopaedic medical team, perhaps a cultural shift, or the meso level of my practice. There are many social stereotypes surrounding various specialities in medicine. The God complex is often associated to surgical and orthopaedic specialities, as Horenster and Pyra identified in 2017. These stereotypes can influence junior staff greatly in their ability to work effectively in their career progression. This is especially true for my own experience, having never experienced orthopaedics in my very early career as a student or as a qualified nurse. Due to this, I found the transition from medicine, a senior nursing role, to orthopaedics and a junior medical role quite difficult, predominantly due to the social control, the dominant group, and the God complex of the orthopaedic consultants. To ensure they have control of the wards on the junior medical teams and ultimately their workload, the orthopaedic consultants present the social control as or hegemony, as Gramsci would identify in 1989. This hegemony would describe and ensures the viewpoint of those in control is accepted as common sense by the other classes due to other options. In my own experience, there was no understanding of the trainee ACP role at the start of my employment by the orthopaedic consultants and my nursing colleagues also. However, following 2 rotations of junior doctors and the fact that 2 senior nursing staff left and 5 further trainee advanced clinical practitioners were employed, a change began. It appeared that the orthopaedic consultants acknowledged my role due to my permanent employment and suddenly found me useful. I knew their patients and their ways of working, which became invaluable to them to acknowledging my role. But why did this transition take nearly 18 months? I was in trauma meeting most days, I attended clinics, ward rounds and took direct care of their patients. So why were they so unaware of my role? Although nurses widely acknowledge the need for changing roles and the need to upskill to combat doctor shortages and ensure greater patient contact, physicians work in very different ways. The orthopaedic department, and consequently my job role, is based on a medical model, a term that's coined by many and understood by few. A medical model shows physicians applying knowledge of anatomy, biochemistry, histology, and pathology with an emphasis on the abnormal. This is very contrasting to a nursing approach, or nursology, where nurses focus on testing, dissemination, and discipline-specific knowledge to collaborate to address the health of humans in a variety of environments, from a high-level wellness to dying across the whole lifespan. This approach of abnormalities versus the whole person was quite apparent when I started my new role. However, this fragmentation, as Van Zooskas and Watkinson identified and observed in 2007, between nursing and medicine can lead to a need for a blending of roles. This could be in a positive way, such as in the form of advanced clinical practice. Perhaps how I worked was very much still within nosology at the start of my career, and not the medical model, and I was yet to adapt. However, having completed my assessment qualification, my prescribing qualification, and been employed for 18 months, had my way of working changed? Had my own professional identity merged to incorporate both medicine and nursing? Did I now utilise the medical model as opposed to nursology within my practice? Perhaps. I still identify myself as a nurse, even though my job title doesn't. Yet I know my perception of care and my skills as a practitioner are now very different. It could be argued that as I became more useful, the orthopaedic consultants acknowledged this, as well as my role being advantageous to them, especially due to our permanent role within the department, in contrast to the ever-changing trainees and locum doctors. Now finally accepted by my senior orthopaedic colleagues, I began to question my own professional identity. Having transitioned from a sister on an assessment unit to a trainee advanced clinical practitioner, a brand new role, I felt my professional identity had been questioned. I'm still a nurse and proud to be so, but am I also a doctor, a fake doctor, a practitioner, or do I have no professional identity at all? From the definition of an ACP by Health Education England, it would appear that advanced clinical practitioners are a profession within their own right. However, due to the multiple professionals involved, advanced clinical practitioners can be governed by many professional bodies. My nursing regulation means I am limited to the Code of Practice 2015, which clearly states necessary training must be undertaken before carrying out a new role. I have struggled with this at times, as a trainee ACP, we are supported by the junior and senior physicians who provide training as well as attending university, but we still fulfil a role within the trust. We are expected to provide practitioner service, working as a ward cover at the weekend. Although competent and only starting the role having completed my assessment qualification and advanced life support on an independent basis, I have often questioned the suitability and safety due to my incomplete training within the support of my code of practice. Am I working beyond my scope of practice? Hence, I only work within my own competence of advanced life support, advanced physical assessment and consultation skills, and non-medical prescribing qualifications, deferring to the on-call SHO for support. This ensures I work within my own professional regulation of the Nursing and Midwifery Council. This micro view of my own indemnity, professionalism and identity has often led me to doubt my ability to complete the programme of study and be a successful autonomous practitioner by February 2018, especially as there appears to be a continuous fight between service provision and training requirements to fulfil my own training needs. This concept of professional identity amongst advanced nurse practitioners, as they were in years gone by, is not new. In 1999, a study completed by Woods identified that the process of advanced practice training requires a reconstruction of an individual's practice from year one to autonomous practitioner. The individual's practice doesn't only change, but their references of support for success also changes. This study was small and could be viewed as limited due to the very small sample size. It could also be argued that, in comparison to this, advanced clinical practitioners are comparable to junior doctors due to their similar professional frames of reference. Yet this comparison has been criticised in more recent years by the likes of Brian Lucosius in 2004, predominantly due to a lack of acknowledgement of the complexity of care that those in advanced clinical practice roles undertake. These provide a positive experience for their patients as nurses working in advanced roles. I would agree with this, as in my own opinion, I feel the care provided by myself and my nursing colleagues is more holistic than that of my medical colleagues. This is similar to the findings of Kerr in 2016, who discovered that advanced practitioners from a nursing profession remain focused on their nursing identity and predominantly the compassion and care they bring to the role. In conclusion, in my own experience, time is a major influence, especially if medical stereotypes are to be believed. The orthopaedics colleagues and my consultants there had to acknowledge my usefulness before I felt validated in my role. Although this took time, I now feel utilised and accepted within my working environment. Although this has made me question my professional identity, it appears I'm not alone in this experience. For many, it appears this is predominantly due to the changes in job role, responsibilities, and professional terms of reference. Furthermore, the lack of acknowledgement from their medical peers and the transition into the medical model of working can influence an ACP such as myself in the acknowledgement of their professional identity as a nurse, junior medic, or practitioner. However, hopefully, the future is bright. My senior colleagues now know who I am and validate the work that I do. We have had 5 new trainee advanced clinical practitioners employed who were also acknowledged by my orthopaedic colleagues. Hopefully, as I progress through the next 2 months of practice to complete my training programme, my professional identity will become clearer as I lose my trainee title and become an autonomous advanced clinical practitioner. Thank you for listening. Here's a list of my references should you wish to use them. Thanks.